Okay, thank you. So as you mentioned, I'm involved in a variety of research studies focused on neurodegenerative diseases, all of which cause dementia or cause what we call spinocerebellar ataxias or other motor dysfunctions. And some of these studies include clinical trials that are sponsored by industry groups. Some of the prescribing I will talk about is not based on any drug being evaluated and approved for the purpose of treating these dementias per se, but a lot of it is based on experience. Young onset dementias are typically defined as dementia arising in people who are less than 65 years old. That's the classical definition. And most of the people that we see are in their early 60s or 60s or younger. And they have a variety of syndromes. So there are different kinds of presentations, different kinds of phenotypes. And there are different diseases, and therefore you'll expect them to have different pathological underpinnings, different genetic determinants as well. And these differences in phenotype, in the underlying pathology, influence how we go about diagnosis and how we go about providing care. And they're also the subject of research that's intended to clarify the pathophysiological process by which these conditions develop. And the major reason to do that is in order to identify steps along those pathophysiological cascades or processes that can be exploited for drug development to bring about medications that can cure these conditions. On this panel here, on the left is Dr. Alois Alzheimer, for whom Alzheimer's disease has been named. On the right, his very first patient, the index patient, Augusta Beta, who he had met in the 1890s. And at the time, she was already very confused. Just a moment, I got a message about the stability of my internet connection, so I'm going to mute my video. She was very confused. She was forgetting things rapidly. She had no knowledge of who she was, really. She had lost knowledge of her own biography, and she was disoriented. She had trouble. She had a severe degree of cognitive impairment. He recorded the progress of her condition, and after her death in April 1906, he examined her brain, and what he observed was, first of all, this is not her brain, by the way. But what he observed was gross atrophy of the brain. And along with that, what we see in the panels below. So here you see essentially clumps of amyloid in the brain, which are extracellular deposits, so deposits of amyloid protein in the brain parenchyma, which we call amyloid plaques. Here you see within a neuronal cell, clumps of what are essentially polymerized tau protein, which make up the tangles. And then you see the various neuropil threads as well, surrounding a amyloid plaque here. And this is just a lower magnification view showing myriad plaques and tangles. And these two pathologies together constitute what is called Alzheimer's disease. But the important point in all of this is to note that August Dieter was 51 at the time of her death. And so she developed, today we understand Alzheimer's disease as a disorder of late life, but in fact, the index case was in her 50s, developed the illness in her 40s, died at the age of 51. And so it was a young onset Alzheimer's disease. So there are, as I mentioned earlier, many syndromes. Alzheimer's disease is mostly understood to be a disease of forgetting. So people have profound memory loss, profound amnesia, anterograde amnesia, and along with that, confusion, disorientation to time, eventually to space. They have a variety of neuropsychiatric states, including anxiety, depression, irritability, and agitation, sometimes aggression. And in some cases, they may have hallucinations and delusions. Now, on the other hand, frontotemporal dementia is characterized by disintegration of social conduct, and I will illustrate in a moment. So these are people who are not forgetful. They're not confused about time or place, but they misbehave because they have lost their social knowledge. You also have other phenotypes. For example, Lewy body dementia, the forgetting, confusion, inattention that might mimic Alzheimer's disease is also accompanied by Parkinsonian state and gait instability and then frequent falling. So there are a variety of phenotypes. They tend to present in particular ways. They tend to evolve in particular ways. And we exploit this presentation and the chronology along with the radiological correlates and other physiological correlates to make diagnoses. Let's illustrate frontotemporal dementia here. This is a technician. This patient was at the time of her presentation a technician. She was 55. She had difficulty. She developed difficulty finding words. So when she was speaking, she would halt to find the right word. So this translated to a disfluent speech. Along with that, she was repetitious. She had what we call stereotypies, meaning that she would have particular phrases or statements that she would repeat as habitually. And then she also had echolalia, which is essentially mindless repetition of what others are saying. Now, in the second year of this illness, his work efficiency deteriorated, and this was because he was confused. His reasoning was impaired, and so he had to go on leave and eventually lost a job. He was also at home, childlike, impulsive, uncaring. He would insist on watching the same TV show, sometimes the same episode over and over. So he'd rewind it and then he'd watch it again if he could. And this, of course, is annoying to people in the home. He had become crude in his behavior, so he would intrude on strangers. When food was served, he would eat out of the serving bowl without waiting. When out shopping, for example, he would jump the queue. He would be talking to people, he would suddenly walk away. And he was he had become very restless, so he'll bike, he'll swim, he'll run, and he couldn't stop. So his wife had arranged for him to volunteer. It wasn't real volunteering. What she did was she attached him to her maintenance crew at a nursing home that she had a relationship with. So he'd follow them all day long, handed off from shift to shift, and that's how she kept him busy. So when I saw him in the third or fourth year of illness, he was pleasant. His mental state examination in terms of depression, anxiety, psychiatric phenomena was fine. And he did not have euphoria. He was not psychotic. His speech, as I mentioned, was mildly non-fluent. The mini mental state exam score, for those who are familiar with the mini mental state exam or the MMSE, was 29, which is essentially a near perfect score, because a perfect score would be 30. The brain MRI scan showed right temporal atrophy, so focal atrophy of the right temporal lobe. And then a year later, he developed pronounced preference for sweets. He was foraging, meaning hunting for food, so he could not stop eating. And then 2 years later, he was admitted to residential care. And when I saw him, it says here 6 months ago, when I saw him in the fifth year of his illness, the mental state exam score was still relatively high for somebody with this degree of dysfunction, so it was 27. Now, frontotemporal dementia. So this illustrates frontotemporal dementia, which is essentially a condition characterized by coarsening of temperament, of dispositions, of judgment, and comportment. And so these people have dysregulated emotions, drives, and self-control. And they also have disintegrating language and communication. There is more than one phenotype. There are those who have a behavioral phenotype in which there are combinations of indifference, impatience, carelessness, jocularity, insensitivity, and so on. But you see the list. Or they have language problems. So they may have effortful, disfluent, agrammatical speech that is reminiscent of Broca's aphasia. Or they might have fluent speech, but it is devoid of content, and so it's vacuous. And along with that, they'll have trouble naming objects, naming people, naming objects, and they'll have loss of word and object knowledge. And so they progressively lose knowledge of what words mean. They lose knowledge of what objects are. And typically this loss of this agnosia for objects begins with with animate objects, and then progresses to involve inanimate objects. And the loss of word knowledge begins with less familiar words and then gradually intrudes into everyday speech. Now, when Arnold Pick and others, Paul Serio and Desjardins, when they defined the signal, the very earliest cases in the 1890s, the pathological underpinnings included focal frontal atrophy, which is illustrated here on gross examination. And so what you see here, you could call knife edge atrophy, in which your frontal lobes, as you can clearly see, feature marked atrophy. So there's thin gyri, widened sulci. Now, here's another vignette, similar presentation. In this case, insidious lapses in memory and judgment. This person had become aloof, also had poor self-control, had wild behavior in public, including intruding on people with rude comments, compulsively shopping for groceries, and she was also failing at work. During sleep, her legs were restless, and she was also sleeping too long. She was fidgeting, rubbing her fingers, tapping her legs when seated in public, so she looked like a very restless person. And she had a tendency to wander away as a child might. If, for example, you're taking a child, say, to the market, the child may wander off, forgetting that they're walking with you because they're distracted by something. This was the same thing. So family, when they were walking with her, had to hold on to her to keep her from wandering away. Her mental state exam score was also quite high. And in her case, the brain MRI scan at the time was normal, whereas the brain FDG PET scan showed diminished uptake of the tracer in the frontal lobes. This patient is shown, this is her here. This is her here, sorry. She's now deceased. This is her mother. Now, at the time I saw her, she had this cousin in Nebraska, also affected, who had an advanced stage of the illness. We eventually had the opportunity to examine the brain of her cousin, and it was on the basis of that cousin's brain that we organized genetic testing for our patient, and then identified the genetic mutation on chromosome 9, what is called the chromosome 9 open reading frame 72 gene. And it is this genetic mutation that had been traveling in this family for a number of generations that was responsible for the illness of this patient and her cousin. Most recently, this one here, who is shown here as unaffected, is now affected and is now in care. So another point that this case illustrates is that many of these conditions are hereditary compared to late life dementia, or let's say late life Alzheimer's disease, young onset Alzheimer's disease, young onset dementias more generally have a higher proportion of cases that are hereditary. They also have different kinds of pathology. This is illustrated here for frontotemporal dementia. There's actually a variety of pathological findings depending on the phenotype, depending on the genetic cause associated with the frontotemporal dementias, and that's illustrated here. In the top panels, what you see are various morphologies of essentially tau pathology. Here's the classical PIC body in a patient with frontotemporal dementia. Here you see a tufted astrocyte in a case of progressive supranuclear palsy. And here you see an astrocytic plaque in the case of corticobasal degeneration. Now, these are all tau-based pathologies. And here you see a different kind of pathology, what we call fusion sarcoma, or FUS pathology. These cases typically develop dementia when they're in their late 30s, early 40s. It's typically a fulminant presentation of behavioral dysfunction of the kind that I've described. And then down here, E to G, what you see are different kinds of pathologies. These are not tau protein based. Instead, they're based on a protein called TDP43, which is abnormal in frontotemporal dementia specifically. And there are different morphologies depending on what kind of gene is responsible for the frontotemporal dementia. And here, what you see are P62 inclusion bodies in the dentate granule cells of the cerebellum. In frontotemporal dementia caused by the C9 mutation. So the patient that I just illustrated with the family history had her cousin, when we examined her brain, she had the P62 inclusions in this cerebellum of the brain. And it was that finding, along with TDP43 pathology in the cortex, that signaled to us that this was probably a case of a C9 ORF72 mutation. Frontotemporal dementia is frequently hereditary, although the majority of cases are still sporadic. Most of these mutations, about 70% of them, are caused by mutations in 3 genes in the MAPTau gene and the progranulin gene, or in the C9 ORF72 gene. But there are a number of other genetic causes. These are all these genetic mutations are inherited in autosomal dominant fashion, and they are linked to particular phenotypes, but in an imperfect way. Now, most cases who have semantic dementia, which is where they lose knowledge of words and objects, will generally have TDP43 pathology, whereas most patients who manifest Parkinsonism will have tau pathology. But other than that, the correlation with phenotypes is imperfect. And so there's multi-level heterogeneity, meaning there is a diversity of phenotypes with frontotemporal dementia. There's a diversity of genetic types, and there's a diversity of pathologies. And so in effect, you could say that these are many diseases marching under one banner. And what you see on the right are just the patterns of atrophy according to the phenotype. Now, Alzheimer's disease in young people is often not amnesic. So it also can be associated with different kinds of phenotypes. So the classical description is a person who is losing memory and is also confused and also has disorientation, maybe has some language difficulties, and then it progresses from there. But you can have other kinds of phenotypes. Here, I show you a person who we see at time 0 here. He's 54. He has a normal mental state, meaning he doesn't have any psychiatric problems, but he has hesitant speech. He has word finding problems, and he's making phonemic, meaning sound errors when he speaks. And he has trouble understanding sentences. He can't do repetition tasks. So if you say, for example, repeat after me, no ifs, ands, or buts, he could not do it. He had profound dyscalculia. He could not perform even the simplest arithmetic, 5 + 3, for example. And he had dyscontrol, that's what apraxia means. He has dyscontrol of his right hand. He couldn't effectively control his right hand or right limb. And he had myoclonic jerking, so sudden jerks of that arm. His minimal state exam at the time was 21. Now, 4 years earlier, he had heightened anxiety, but he had always had an anxious temperament and a history of nightmares. Now, it is to be noted that his paternal grandfather, his mother, and 2 cousins also had dementia. Now, 3 years before I saw him, he had dysgraphia, so he had trouble writing. He was making spelling errors. He had trouble with calculation. And then he develops problems with speech, problems with limb control that translate to difficulty even for not knowing how to dress himself. And then eventually, a year after I see him, the minimum mental state exam score is 15. The Montreal Cognitive Examination score is 5. He's developed a REM parasomnia, meaning that he's enacting his dreams when he's sleeping. So he's moving, he's talking as if awake. And it's at this point that memory loss becomes prominent. And he went on to develop postural and gait problems. When he died, we examined the brain and showed it was Alzheimer's disease. So from young-onset Alzheimer's disease, you can have amnestic phenotypes. You can have an apraxic phenotype like I've just, you can have, an aphasic phenotype like I've just described, in which case they have mixed fluency and semantic deficits, meaning that they stutter, they struggle, they stumble. So it's Broca-like, but they also have loss of content. And so it's empty speech. You can have what we call posterior cortical atrophy is the common name. Visual, I prefer to call it a visual perceptive deficit, in which people have primarily a loss of visual perception. And so they can't perceive space. Very often the first complaint is, I can't see. But when you test their vision, when they go to the ophthalmologist, for example, vision is fine. They eventually develop speech difficulties and inattention, and these people are very prone to hallucinations. So this primary visual perceptual difficulties is one of the classical presentations of frontotemporal dementia. So uncommon, it typically arises in the mid-50s, and it evolves gradually like other phenotypes of Alzheimer's disease. You can have executive dysfunction as the leading edge of the syndrome. And so people become disorganized, confused, inattentive. Their behaviors may become asocial. Or you can have a presentation where it's primarily loss of control, limb control. And so people become discoordinated in their movements. And it's typically on one side. Now, when it's young onset Alzheimer's disease, as I mentioned, the phenotypes are usually focal, meaning primarily affecting memory, primarily affecting language, primarily affecting visual functions, primarily affecting executive functions. Whereas in older people, it's predominantly amnesia. The young onset cases have a high rate of hereditary mutations, mutations in the APP, but it's only about 10 to 20% compared to, and so the majority are still sporadic cases. These are mutations in presenilins 1 and 2, or the amyloid precursor protein. And these mutations in presenilin 1, for example, onset is typically by age 50. For the presenilins 2 and APP mutation carriers, they develop illness by the age of 60. Now, with the young onset, typically with Alzheimer's disease, we know apathy, depression, anxiety are widespread. But in the young onset cases, you can have REM parasomnias that may precede overt cognitive impairment by several years. And so people may already have complained of talking during sleep, moving during sleep. People may have hallucinations and visual illusions at the beginning of the illness, particularly in those who are developing the posterior cortical atrophy syndrome. Myoclonic jerking is common, and they have a higher risk for seizures. Apraxias and Parkinsonism are common. They're not as common in the older people until late in the illness, whereas they may appear early in young onset Alzheimer's disease. And when you test them, even in the amnesia predominant people with young onset dementia, with young onset Alzheimer's disease, they have worse performance in neuropsychological tests of attention, executive functions, visual perception. Because there are those who think that dementia cannot happen in young people, sometimes diagnosis is delayed. And sometimes if the psychiatric or motor complications misdirect the diagnosis. And then, of course, there are some practical issues that we encounter here. For example, if a person is still young, they may still be raising children. They may still be working. They could lose the job. If they lose the job, in parts of the world where your income is tied to your health insurance, that becomes another kind of problem. Now, when you look at the brain scans for diagnosis, what you'll find is that in the young onset cases, abnormalities tend to be focal. Depending on the phenotype, it may be predominantly parietal or frontoparietal atrophy, or it may be predominantly frontal atrophy. There's not a left-right asymmetry in terms of the atrophy pattern is not uncommon, so atrophy could be worse on the left than on the right. Whereas in older cases, you typically see global atrophy, although sometimes you might see a little more atrophy in the hippocampal areas. And the FDG PETs or perfusions, the SPECT scans will mirror these patterns. These days, we're able to do assays of amyloid and tau. And so we use the CSF assay frequently to be able to tell if a case that seems ambiguous is Alzheimer's disease or not. The ApoE4 protein has been linked to risk for Alzheimer's disease, generally, not in the young onset cases, but in older onset cases. But ApoE4 assays have no diagnostic value. Now, the histopathological changes in the brain are similar for young versus old onset Alzheimer's disease. The only difference is that on gross examination, there might be focal atrophy in the younger cases compared to the older cases. So the natural history, as I've alluded to, when we are presented with a case, the natural history informs how you make a diagnosis. So most people understand that dementia begins, Alzheimer's disease in particular, but dementia generally in the public perception, begins as an amnesic condition. People are forgetful and then things progress. But in fact, as I've already illustrated, the beginnings could be aphasia, it could be behavior. It could also be visual perception. That is, so people might be unable to keep their car in lane. They have difficulty with depth perception, and so they stumble when they're going down the stairs, when they have to walk over a curb or when they have to descend stairs because they can't judge the distance properly. Or they can't find, they're in a restaurant and they use the restroom and they can't find their table. Or they can have, as I mentioned, motor control deficit. So let's say a person begins with aphasia. That will then be this green line here. And so that's the first symptom. And then over time, they may develop language, they may develop apraxia, or they may develop visual perceptual deficits, they may develop amnesia, and so on. Or they might begin with amnesia and then progress, that is progressing. Sometime afterwards, they develop executive dysfunction or disorientation, and then develop maybe language dysfunction. And so that by this point, they have deficits in multiple domains, but the very first symptom is also the worst. So it's a predominantly amnesic dementia, or it's a predominantly aphasic dementia. And this information has diagnostic value. I'll illustrate that soon. So the presentation is important. The chronology is important. The tempo of progression, that is the speed of progression, is relevant. So if a person, for example, in late 2020, I met a man who was profoundly disabled. He could not say his own name, could no longer walk, and he had developed dementia. He had developed problems 2 months earlier. So that turned out to be a case of Creutzfeldt-Jakob disease, a very, very rapid progression. So the tempo, the speed with which things progress in itself can be diagnostically useful. So if a person goes from being normal to being severely disabled in a matter of months, it's unlikely to be Alzheimer's disease, it's unlikely to be frontotemporal dementia. You would be considering Creutzfeldt-Jakob disease, you may be considering some autoimmune disease. You might want to look for space-occupying lesions in the brain and so on. So it's the abrupt dementia, rapidly progressive dementia has a differential diagnosis. Now, interview, the basis, I think what I'm leading up to is that the basis for diagnosis is the interview. It is the interview that allows you to know the presentation, that allows you to know the chronology. How did things develop from that presentation? How fast is it changing? And then what else is happening? What I like to call complications. Is the person, are they telling you the person now has a tremor? Are they telling you the person is shuffling when they walk, which would suggest Parkinsonism? Are they telling you that the person is coughing and choking when they eat, which might suggest bulbar or pseudobulbar palsy and therefore suggest FTD with ALS? So what is the story? And then you do a mental state and a cognitive examination to flesh it out. And that information helps you pinpoint a most likely explanation for the syndrome. And then you do the various tests to evaluate your preliminary diagnosis. So here's a clinical decision pathway we published a number of years ago. And you have, so if the syndrome is primarily amnesic, you're thinking Alzheimer's disease. If it's amnesic but has Parkinsonism, then you will also consider Lewy body dementia. If the rate of progression is extremely rapid, then you'll consider this could be an autoimmune dementia. So maybe there are autoantibodies that are attacking the brain. There may or may not be some occult cancer generating those antibodies. Now, if it's non-amnesic, it may be predominantly aphasic. If so, then the leading considerations are Alzheimer's disease and frontotemporal dementia. If it's predominantly visual perceptual dysfunction, then Alzheimer's disease is a leading consideration, but dementia of Lewy bodies is a possibility, and so on. So you get the idea. When there's abnormal conduct, you'll be thinking maybe frontotemporal dementia. If it's starting out with hallucinations, you might think Lewy body dementia, Parkinson's disease dementia. So understanding the primary syndrome on the basis of the interview and the examination allows you to form at least a preliminary diagnosis, which you will then perhaps buttress by doing tests. I think I've talked about this, I'll skip over that. Of these tests, the most important is the brain MRI. And so here I illustrate the utility of brain imaging. This is a patient with frontotemporal dementia. As you recall, when I showed the brain specimen earlier, I showed you a case of focal frontal atrophy. Well, here, what this image illustrates is the same. Focal frontal atrophy. This is a sagittal image, a sagittal slice, midway. Here, what you're looking at in this axial image is bilateral anterior temporal atrophy that's very pronounced. It seems to be worse on the left than on the right. Now, this is a patient who will have profound loss of word and object knowledge, but will also have a significant loss of knowledge of who people are because of the atrophy on the right side, and will also have significant behavioral disturbance as a result of this atrophy on the right side. Now, here you have focal atrophy of the perisylvian area, which is what you'd expect for a person with a Broca-like aphasia. So they'll have disjointed speech. Their speech will be effortful, agrammatic, telegrammatic, meaning that they use very few words to try to communicate meaning. Now, very often the MRI scan is normal. And what we do is we get an FDG PET scan, but one could get a SPECT scan. SPECT scan is much cheaper, so it's feasible in many places where an MRI, where a PET scan might not be. And what you're looking at here is reduced tracer uptake in the temporal lobes, here in the anterior frontal lobe, and here again you can see the difference between the frontal lobes and the rest of the cortex. And so using these images here, you would be able to make to confirm your clinical diagnosis of frontotemporal dementia. Now, visual rating scales exist to rate, that a radiologist can use to rate the severity of atrophy, but these are not typically used in the clinic. They're typically used in research, sometimes in clinical trials. They have a useful degree of inter-rater reliability and validity, but they're not very sensitive for diagnosis, as you can see here. It depends on the phenotype, but I would not recommend using a visual rating scale as the basis for diagnosis. The qualitative appraisal of the scan usually suffices. Now, this is a young-onset Alzheimer's disease, and from the patient I showed you earlier, the 54-year-old man who had a lot of aphasia and some apraxia. And what you can see is it's difficult to discern whether there's atrophy posteriorly here. But then when you look at the FDG uptake scan, what you can see is reduced uptake in both parietal and occipital areas. You can see it's quite clearly. And this is typical of young-onset Alzheimer's disease and the posterior cortical atrophy in particular. These days, we have PET ligands and PET ligands that allow us to, as I mentioned earlier, label. I'm not sure I mentioned this. We have ligands that can identify amyloid in the brain and tau in the brain. This is illustrated here for Pittsburgh compound B, which basically successfully labels cases with, so this is the Pittsburgh compound B, this is FDG PET. So the FDG PET shows the patterns of reuptake abnormality, glucose reuptake, of tracer uptake abnormalities according to the phenotype. Here, as you can see, the scan is only positive in those cases with amyloid. So this is a language variant of Alzheimer's disease. The language is an aphasic presentation of Alzheimer's disease. And here you have the classical presentation, the amnesic presentation of Alzheimer's disease. And these are the two cases that show amyloid in the brain. And the others, frontotemporal dementia and normal controls, do not have uptake. And so you can see immediately that when you have an ambiguous case, an amyloid PET scan can help you make the diagnosis. This shows tau PET scanning and makes the point that tau PETs, the distribution of tau PET abnormalities can vary by phenotype, and that can have diagnostic utility, but we're still in the process of working out how tau PET scans fit into clinical care. Genetic testing is only relevant where you have a clear-cut where you have a family history that suggests inheritance. Classically, people will say 3-generation pedigree, but sometimes you don't have enough information. But you might have for 3 generations, but you might have information for 2 generations that makes the case, in which case you can go forward with genetic testing. That the genetic testing is negative does not mean the person doesn't have the diagnosis, because, as I mentioned, the majority of cases will be sporadic. So in terms of care, I find that we are in a number of roles when we're dealing with someone who has a neurodegenerative disease. The first is to explain the problem. So sometimes that's the main reason they're in front of you. What is going on? And that means your role is to make a diagnosis, which means that what you're going to be doing is providing an evaluation, directing other investigations, blood tests, brain scans, mainly brain scans, maybe neuropsychological assessment, and so on. You may make some referrals, if, for example, to ophthalmologist to confirm that visual problems, that the visual perceptual complaints are not due to visual problems. And then, but ultimately what you're trying to do is make a diagnosis. But sometimes there's a crisis. The employer has said, person is no longer performing properly, they might be dismissed from the job unless that is addressed. In that situation, what you're trying to do is solve this problem. Make sure that the employer knows this person has an illness, and then get them perhaps sick leave so that they can get attention they need. So you're intervening in a crisis, and then you're going to necessarily make a diagnosis in order to put together some rehabilitative plan. Sometimes it's the stress. The person is agitated, or they are having hallucinations and illusions that are frightening. Alongside making a diagnosis, your purpose is to provide relief, to alleviate the distress. And sometimes people, they know what the diagnosis is, they have prescriptions to help, they have a rehabilitative plan of care, but they're struggling to take care of a loved one, or or to understand their prospects and how to live life. And this is where we provide guidance. So we're providing clarification when they have questions, we're providing support, and we're providing direction to deal with demoralization, to deal with stress, not just in the individual who has the problem, but in their caregivers. So that's dementia care in a nutshell. Beyond that, we're trying to individualize it you have to still individualize care, because some people need more rehabilitative intervention. Some people need to have symptoms ameliorated. You can prescribe medications for that. There's some psychotherapeutic approaches. When it's rehabilitative care, for example, if they're having difficulty with walking, you might have a physiotherapist work with them. You might have caregivers be in skills programs or in counseling programs to help them cope. You might have to do dietary interventions or nursing care interventions when things get more advanced, to make, as I said, to provide more assistance. And ultimately, where we'd like to be is we'd like to be able to cure things. We'd like to be able to prevent things. And that's where a lot of the research today is focused. There are a variety of psychosocial interventions that are essentially leveraging advances in psychotherapy and in care support programming to help either the individual or the people around them manage the disease. And so these include programs that are intended to troubleshoot behavioral problems, programs that are intended to provide caregivers with skills and coping mechanisms, as well as a variety of programs that leverage design. So you can have alarms so that when a patient wakes at night, people know and they wake up so that they don't get themselves hurt. You might have smartphone and tablet apps to help people communicate. Here in Baltimore, and Dr. Samuels will be talking about this later, we have programs that go in the home to help people. We also use medications, cholinesterase inhibitors for Alzheimer's disease, for example, but also a variety of psychotherapeutic agents to deal with the various problems. This is essentially psychiatric care repurposed for the dementia context. So if people have anxiety, for example, we would use we typically will use SSRI antidepressants. If there are hallucinations, if there's paranoia, if there's irritability or aggression, especially if it's arising from paranoia, we might prescribe neuroleptics. Sometimes we provide benzodiazepines are very effective, clonazepam in particular for myoclonic jerking, for REM sleep behavior problems, REM parasomnias. They are useful temporarily for agitation or aggression in acute situations. You can see the list. The one thing, hyperphagia, overeating, is very common in frontotemporal dementia, and the one medication that sometimes helps is topiramate, to dial down basically the constant hunger, for want of a better term. So there isn't any, as I say, it's all ameliorative therapies. There aren't any medications yet that can provide cure. The research, and this is, I think we're close to the end now, the research that we're doing now is intended to eventually lead us to cure. And so you can think of this as the conceptual model. So there's an early stage where there are molecular and physiological events, but the person is still functioning normally. So this is the prodrome. During the prodrome, there's already evidence that brain volume is declining in particular regions of the brain. A threshold is reached at which dementia develops. It could be Alzheimer's disease, it could be frontotemporal dementia. This model is consistent for all. And during that time, the molecular cascades are reaching maximal intensity. So it could be inflammatory cascades, neurofilament accumulation, other molecular pathologies. And so you enter a transitional stage in which clinical symptoms begin. And then you cross another threshold in which that translates to dementia. So that's the working model. If we can interrupt these molecular cascades and prevent this brain atrophy, then the idea is that we can prevent the clinical decline. Also, if we understand these events, then we can test new medications effectively in clinical trials without waiting for people to have symptoms. And there are various consortia that we're involved in. There are various groups around the world that are coming together to investigate these things. And some of the discoveries include clarifications of how early atrophy begins in the brain, how early amyloid deposition begins in the brain. We know that this is 20 to 30 years before clinical symptoms. We're beginning to more carefully define the transitional phase so that it can be recognized, and therefore we can facilitate earlier diagnosis. And then we're beginning to identify molecular changes. Neurofilament light chain is one of the better described ones, but also plasma tau, plasma CSF and plasma tau assays are showing promise for diagnosing Alzheimer's disease. So we might get to a place, maybe in the next 2-3 years, where you can diagnose Alzheimer's disease on the basis of a blood test. How is it that some brain regions of the brain degenerate and others do not? How do you get this selective atrophy? This is still an area of active investigation. But there's an idea that there's selective atrophy in various functional connectivity networks in the brain, and that it is this selective atrophy that results in people having one syndrome versus the other. So there's a lot of exciting work going on. There's other work going a step lower, looking at various molecular cascades, whether it's dysregulation of amyloid processing or cellular repair mechanisms, axonal transport mechanisms, endosomal trafficking, and so on, mitochondrial dysfunction. And the idea, as I mentioned earlier, is to identify points that you can interrupt to prevent the neurodegenerative process. I will stop here. These kinds of activities, whether it's a clinical activity or the research activity, it involves a community of people, and these are the people that I acknowledge on this slide. So thank you for your attention. And I'll stop here so that there's at least a little time for questions.
Thank you, Dr. Onyike, for the presentation. I hope you can hear me.
I can hear you.
You've actually covered a topic which we tend to neglect, dementia in the young. And from studies which are ongoing, we've noted that we have quite a number of people who develop dementia early, we actually found about maybe about 35% of histopathological samples had tau or tested positive for tau.
Yes.
Though the patients, these are less than 65 years, had no symptoms. And you correctly put it that usually the histopathological findings tend to precede the clinical symptoms.
Yes.
So that is, I think, an area for us to explore. I just have a question. Do you know if the percentage of the young patients with dementia who actually also have a Parkinson's disease? So I'll leave it at that, then probably take a few more questions which you can respond to from the audience.
Yes.
Maybe you could raise your hand and of about 3, then we'll allow him time to respond. Thank you.
Okay, thank you. Yeah, so we don't know what percentage of young people with dementia have Parkinson's disease. I think most people who have Parkinsonism, who have young-onset dementia, do not have Parkinson's disease, but rather they have Parkinsonism in association with either Alzheimer's disease, frontotemporal dementia, or some other condition. Now, someone is asking, I think it's Dr. Joy Mirembe is asking about lifestyle differences to preventive measures. I think the best, what seems to be the most effective in terms of the data, both animal data as well as epidemiological data, is physical activity, so exercise. Some people have even gone so far as to recommend, for example, walking 30 minutes, at least 30 minutes, 3 times a week as a minimum. Now that's obvious, that advice is tailored to older people who might otherwise be sedentary. I think, for example, in Nigeria, where I grew up, in Uganda, where you are, elderly people are still moving around. So they're much more active, is my perception. Physical activity. Now, beyond that, dietary interventions that are designed to maximize cardiovascular health. So reducing carbohydrate intake so that people don't become obese. Managing cholesterol intake. These are the 2 things that these are 2 of the things people have emphasized. And then the third thing is maintaining socialization, maintaining social engagement. Historically, for a long time, African societies have always been very social societies. You know, extended family networks are actively cultivated and actively maintained. But perhaps we're beginning to see a change, you know, where young people are very far away from their parents and that kind of thing. So socialization is crucial, and finding ways to ensure that continues to be at a high level is important. Now, someone is asking, in an environment where you might have a hard time finding specialists, what can you do? I think the basics for management will be, you know, at least one can do a clinical interview and ask questions around memory, speech, orientation, to time in particular, because that's what will change early. You can do a neurological examination. You're watching the gait in particular, the posture and gait. Is the person hunched and shuffling? Do they have tremor, particularly if it's asymmetric? These are the kinds of things that might suggest a neurodegenerative problem. Do they have apraxia? Are they beginning to forget how to use certain tools and objects? Now, if you then have a high suspicion, you can get a brain scan, and if there's an atrophy pattern or an ambiguous brain scan, I think you can then transfer the suspicions to a specialist through a referral. In many cases, you might be able to say, hopefully you'll be able to say, no, I don't think this is dementia, this is something else, and then a referral is not necessary. Sorry, yeah, maybe this is the last question, or is that what you were leading? I don't know if you're talking about that, but let me take this one, and then you can tell me.
Okay, there's also a hand, Professor Noelin's hand is up. maybe she can unmute
Oh,
and
okay,
also
okay. I
ask
will
the question.
pause.
Yeah.
Yes, please.
Thank you very much, Professor Onyike, for this presentation. It has
Thank you.
been extremely enlightening for me, especially in the identification of early onset dementia, because it's always kind of confusing with the symptomatology that is not all inclusive of what I would have expected in an older individual.
Yes.
And so I've learned a lot from this. I just had 3 questions.
Yes.
The first one is with Auguste Dita, the lady who was identified as the first Alzheimer's patient.
Yes.
I'm wondering if at all it could have been an early onset, maybe FTD and not Alzheimer's per se, given the pathology that, crisscrosses, across the various types of dementia. That's just something for me to think about. The second one was with the vignette on the pedigree. I noticed that there were more females affected for the example that you gave. And I know literature has said something about this, though other literature also seems to suggest, it could be either way. Could you kindly comment on that?
Yes, yes.
And then my third question is on with the different ways of presentation for early onset, especially if it is early onset Alzheimer's disease and maybe not FTD. What can we do for these patients? I mean, how early can we start possible treatments that we know may or may not be helpful for these individuals? Thank you.
Yeah, so these are 3 great questions. For the first one, Alzheimer actually examined her brain. So he carefully described the amyloid deposits and the tau deposition, and it was those findings that form the basis for what has come to be known as Alzheimer's disease, the idea that you have amyloid and tau pathology. But as you correctly mentioned, there are other conditions that have tau pathology. We now know that the morphology of the tau pathology are different. And people have actually gone back and re-examined Alzheimer's slides. And so, for Auguste Dita. And so it's been settled that she definitely had Alzheimer's disease. The pedigree I showed you, yes, it's predominantly female. We pondered that one as well, and we're still not sure how that is. We know that in the generation of the patient, the mother of my patient, they were just 3 daughters. So that perhaps partly explains it. In the older generation, there were some sons who went to war, and World War I. And I think 1 or 2 did not return from the war. So I think that could maybe explain part of it. But in terms of the actual genetics, we don't see a female preponderance, generally speaking. Although in Italy, there has been some report that it may, most research shows a male preponderance 4-to-1. But in Italy, they seem to have a 1-to-1 preponderance. And they believe it's because most of their genetic cohorts live in an isolated area. And in general, women tend to live longer than men, and that's why they're seeing more women than men, but we don't know the answer. There's a question here. I know that we're at the top of the hour. There's a question here about strokes and CV. In young people, this is not usually a cause unless there's some underlying condition, maybe some either some disorder of the cerebrovascular system or some connective tissue disorder. And then you have a lot of strokes. But it's not, it can happen that people have strokes by the usual mechanisms. But the majority of young onset dementia, that's due to stroke. Much of the young onset.
As you're looking at the next question, my first question was on how early do we get to treat early young onset dementias, especially if we find them in people who are like 40s, 50s. Is it as beneficial in trying, just like older onset dementia?
In terms of all the activities, not just the prescriptions of medicine. So for example, if a person is already struggling at work, making the diagnosis early and intervening to ensure that that it is understood that they have an illness so that they're not viewed as incompetent and then dismissed, which will cause a loss of income, an abrupt loss of income. So that is one aspect of it. Helping the family cope is another aspect of it. So these are now beyond that. Sometimes medicines will help. For example, if you prescribe cholinesterase inhibitors, they can ameliorate hallucinations in a person who, we find that they ameliorate hallucinations and visual illusions in people who have the visual perceptual presentation and also have hallucinations. So sometimes they can ameliorate some of the cognitive dysfunction. Now it won't prevent decline in the long run, and sometimes the effect is lost over time. But in the short term, you can have some improvement. If the person is also having other kinds of complications, anxiety, depression, those definitely are treatable. So that one can do a lot for quality of life by treating early. Now, as we begin to develop anti-amyloid agents and other things, then it will become a different kind of question, obviously, because now we're moving in the direction of interrupting pathology, and the sooner the better. Because if you stop the neurodegenerative process when the person is very advanced, then they're still profoundly handicapped. And then it becomes an advantage to finding it as early as possible so that you stop the progression when it is very manageable.
Thank you.
There are still some questions in the chat. I don't know if we have a few minutes to respond to them.
Yes, absolutely. So the one person is asking about the stages of dementia, and I think, to put it simply, well, one, I can refer you to what is called the functional assessment staging for, I think it's called FAST is the acronym for dementia, that you can find online. But just to summarize, if you think of mild dementia is when the people have symptoms, they're noticeable, but they're still able to engage in everyday interactions. You can still converse with them. They still have a sense of their identity. Now, when it's moderate, they're now becoming handicapped in everyday ways. So they need help dressing. They need help with food preparation. They might be wetting and soiling themselves, things like that. And then when it's severe, that's when, people are needing active assistance, hands-on care. That's when we would say they're in a severe stage. So I hope that is helpful. Yes, it is a lifelong condition. The caretakers certainly need to be dedicated, and that's why there's been a lot of effort developing a variety of psychosocial programs to help the caregivers in terms of information as well as skills. I see there's a hand up from, is it Dr. Redmond?
Yes, Dr. Redmond, maybe you could ask your question.
Yes, thank you so much for the presentation. My name is Harriet Nankabya. I'm a geriatrician here in Uganda. So my comments would be, hello?
Yes, I can hear you.
My comments would be, one thing, as we manage the dementia patients are not managed like the way we manage, let me say, malaria patients. So when you get these people, we actually find out, is it a reversible or irreversible? I have some bit of young people who are got the dementia way back in their 50s, and now they are actually 68, 60 something. So we find out, after finding out, you talk to the family, do the family meeting, and then in the family meeting, there are key factors to discuss. One is the diagnosis, because nobody would wish to see their family member or their spouse demented. So you need them to understand the disease and what they have ahead of them. And so
Yes.
You do a family meeting, explain to them the disease, and then after explaining to them the disease, you've explained the diagnosis, which is more of clinical, then you go ahead and talk about the caregiver burden, and then the role of medications, and then see whether they've understood. Give them time. Don't start medicines straight away. Give them time to appreciate, and then they come back. Because all we know, if we are talking about irreversible dementia, then the drugs they help in the global functioning of a person and some of the psychological behaviors. So if this family has accepted, then that's when you go ahead and start the drugs. And there are prior things that we do, investigations. You must rule out LBB in a patient so that you don't just
Harriet,
give
can you make it short?
Yes, I've made it short. Thank you.
No, thank you. I think, I think I couldn't have said it better. Yes, no, what you're doing is spot on. I couldn't have said it better. You have to educate people, and you have to assure that they understand, and they are prepared to embark on treatment. Absolutely, I completely agree.
And then we should also avoid antipsychotics as much as possible, because there is a raised increase, an increased risk of strokes in patients with dementia and on antipsychotics. Antipsychotics would be very beneficial in patients who are really actually aggressive. So when you've talked to this family, they'll understand, and there'll be some behaviors that they'll be tolerant to, because they cannot be free from behaviors totally. Thank you. That is my input.
Thank you. Thank you very much.
Okay. Thank you so much, Harriet. And thank you, Professor Onyike. I need to bring this to the end. Thank you, members, for actively participating. And we hope that you participate in the coming presentations, as we shall advertise them in the future. Thank you so much. Have a good day.
Thank you. Thank you for having me.